Welcome all of you to this live program on Orthopaedic Principles. Today, our guest of honor is Professor Peter MacDonald from Winnipeg, Canada. Dr. MacDonald is full professor and Gibson Chair of the section of Orthopedic Surgery at the University of Manitoba. He's also the regional research leader for the Winnipeg Regional Health Authority, the medical director for the Department of Surgery, and the chief research and innovation officer at the Pan Am Clinic in Winnipeg. Dr. MacDonald was also recently appointed as chairman of the Diagnostic and Surgical Recovery Task Force in Manitoba. Dr. MacDonald was president of the Canadian Orthopaedic Association from June 2016 to 2017 and is currently the president of the American Shoulder and Elbow Surgeons Society. He serves on many editorial boards and is also the associate editor for the Journal of Shoulder and Elbow Surgery. Dr. MacDonald is a world-renowned orthopedic surgeon with over 150 peer-reviewed publications and 500 national and international presentations. His research team recently received prestigious research awards, including the 2022 and 2019 Richard O'Connor Award from the Arthroscopy Association of North America, the 2020 Near Award, and the Canadian Shoulder and Elbow Society Best Paper Award in both 2018 and 2019, and yet another award as Paper of the Year in the Arthroscopy Journal in 2020. Dr. MacDonald has a strong record of mentoring residents and international fellows, and this clinical practice and research focus on upper extremity, knee sports injuries, and arthroscopy. He's also the team physician for the Winnipeg Jets and the Winnipeg Blue Bombers. So today it's my great honor to introduce you to Professor Peter MacDonald from Winnipeg, Canada. Over to you, Professor.
Thank you very much for the kind introduction, and thank you, Loy, for inviting me, as well as Dr. Gopalan. And I really am pleased to be back on doing this type of presentation. Last time, I think we talked about multi-ligament knee. This time, we're talking about remplissage, which is a procedure which is slowly gaining more and more popularity around the world. And we've been fortunate to do some research in this regard. So there's my disclosures. And, you know, when we talk about arthroscopic versus open stabilization, not all athletes are suitable for arthroscopic stabilization. There's been newer techniques and instruments such as remplissage and others to make arthroscopic stabilization more easy and more reproducible. And we all know that in Europe, especially, and around the world, Latarjet is a very common, very popular operation, works very well, but has a little bit higher complication rate and a higher long-term rate of osteoarthritis. So in North America, we favor arthroscopic techniques first, if possible, within the results that we can obtain with acceptable recurrence rates. So this is like referencing Bankart and De Beer's famous article in Arthroscopy of 2000, where they first pointed out that there's a big difference in results if you have a bone defect in the humeral head of the glenoid or no bone defects. If you have significant bone defects, then your recurrence rate in non-contact athletes goes up to 67%, and in contact athletes up to 89% with arthroscopic stabilization. So this was the first paper that really showed that the bone defects highly influence the results of arthroscopic stabilization. So which ones are at risk for recurrent instability with arthroscopic stabilization? Greater than 15% glenoid bone loss is definitely a factor. And it used to be 25%. Now some papers, such as Dr. J.T. Tokish, have it as low as 13%. So there's a critical threshold after which we have to do some sort of bony defect type procedure. A large hill-sachs lesion, especially one that's engaging, and anterior or inferior shoulder hyperlaxity, such as we see in the picture below. So glenoid track is also a concept, and there shouldn't be no one measurement that influences your pre-op planning, but it should be everything put together with the history and physical that influences what you're going to do. But one of the measurements you can do is the glenoid track, and we have our radiologists trained to measure this routinely on CT scan and MRI to make sure we know when we read the report whether this is on track or off track lesion. As first described in 2007 by Yamamoto, and it's where the posterior humeral head contacts the anterior glenoid rim, and if the width of the remaining glenoid is more than 0.84, or sorry, the hill-sachs lesion is larger than 0.84 of the glenoid width, then we have a situation where the lesion is off track and we're going to have a higher recurrence rate. So talking about remplissage, it's possible to talk about remplissage without referencing Dr. Eugene Wolf from San Francisco, USA, who was a pioneer of arthroscopic remplissage. And we're really not talking about this type of defect. This is a very large hill-sachs lesion, obviously, probably 30% of the humeral head. And this type of lesion would push us more towards a humeral head allograft. But we are talking about small to medium-sized lesions. And it's important to remember that remplissage was first described as an open procedure by Connolly in 1972 in an instructional course lecture for the American Academy, where he transferred the infraspinatus tendon and a piece of bone actually into the remplissage defect. Then Eugene Wolf in 2004 popularized the arthroscopic portion, where he took the posterior capsule and infraspinatus insertion and created tenodesis. And this is first described at the Nice shoulder course, very popular shoulder course by Wolf in 2004. Now, initially, this was met with some skepticism. It was called remplissage because that's the French for filling. So we reference it remplissage because you're filling up the defect, and it avoids engagement. But a lot of people were skeptical based on, well, does this heal? Does it really do anything? Is there going to be posterior shoulder pain? Is there going to be weakness? Is there going to be loss of range of motion? So there was skepticism. So this is what it looks like when you put an anchor into the hill-sachs defect. Many of you will have experience with this procedure. So what about the technique? And this is important, that it can be done either beach shear or lateral decubitus. And when you are doing it, sometimes it's helpful to rotate the head or apply an anterior directed force. Your scope is anterior, so you can see the defect posteriorly better with the humeral head translated anterior. So we usually view, as I mentioned, anterior superior, and we work posterior lateral on the shoulder. Sometimes there's technical issues with the hard bone in the humeral head. And although newer anchors, you can use an all suture anchor or something like that, or a knotless anchor. But when we first started doing this, we're using traditional anchors, and sometimes the anchors would break because of the hard bone and you had to tap them. So what's the order of the operation? People often ask this, like, do you do the labral repair first or you do the remplissage? If you do the labral repair first, it can make the remplissage harder. You can elevate the labrum, prepare the glenoid neck, do the remplissage, and then complete the bankart repair. The reason that doing the labral repair first makes it harder is because it translates the humeral head posteriorly and makes it harder to see the remplissage. Now, the other thing you can do is take a 70-degree scope from anterior superior, put it in, and look around the corner so you can see the remplissage better, so you don't have to worry about that. I'm not stuck on the order. I don't mind doing the labral repair first, the remplissage later. The reason being is sometimes I'll make the decision on the remplissage based on taking the arm out of traction and putting them in abduction external rotation and seeing how much engagement you get of the hill-sachs. Then I'll decide if the hill-sachs is engaging. So the anchor position, where do you put the anchors? Do you put it in the middle of the defect, or do you put it closer to the edge? You have to be careful of the trajectory of your anchors. I've had a few occasions where the drill or the anchor itself would actually go into the articular surface and penetrate the joint surface. So you have to be quite careful. So this can be technically demanding when you first start. However, after you pick it up, it doesn't take long. It only takes about 10, 15 minutes to add to the operation. So here's some illustration. This is with the hill-sachs defect in view. And you notice that there's no cannula coming into the capsule or through the capsule. You want to keep your cannula extracapsular, and you penetrate with a drill guide that has a sharp trocar on it through the capsule. So you have 2 penetration points so you can create this capsulodesis. And here you're looking at the hill-sachs defect with an anchor going in. This is an all suture anchor going in. And once it goes in, you can withdraw your cannula and see if the anchor is set. And once you determine that it's set, you can move on and put a second anchor through a second poke in the capsule. So that's what it looks like. Now, once you have the two anchors in, then you're in a position to tighten them down. Now you can do knot tying or knotless technique. There are knotless anchors you can use to shuttle one suture into the other and vice versa. And then there's knot tying as well. So either way, the important thing is to get that capsule down to a fresh hill-sachs area so that when you put the arm in abduction and extra rotation, it no longer engages. And there's two actions of it. It's a tenodesis effect. It holds the head posterior. And the second action is it prevents the capsule from engaging on the anterior glenoid. So when it was first, I mentioned the skepticism when it was first introduced. It was Pascal Boileau in France, very well known, of course, who first did a study, a very good study, reflecting on 47 remplissage procedures. And it was level 4 evidence, but it was very well done because he did CT arthrograms demonstrating a healing rate of more than 75% of cases where there's satisfactory healing, and a loss of range of motion, which was feared as being a big problem with this procedure, was less than 8 degrees. 98% of shoulders in his follow-up were stable. So inclusion criteria of his study was traumatic recurrent with a large hill-sachs lesion without significant glenoid bone loss. As I mentioned, probably less than 13%. Exclusion criteria would be the significant bone loss or associated full thickness cuff tear, which is unusual in instability patients. So this is like actually one of our patients in follow-up, and he did CT arthrograms and MRIs to demonstrate healing. This one has nice healing of the two anchors with the capsulodesis. The other thing is that they did a detailed clinical evaluation with independent observers at 6 months, 12 months, and annually, and various quality of life scores and shoulder outcome scores. And this is showing the capsulotenodesis healing, which is more than 75% in majority of cases. So the clinical results, most patients were either very satisfied or satisfied, and they've had a few second look procedures showing healing of the remplissage, much like the previous video I showed you. And the range of motion loss, as I mentioned, was fairly minimal, only 8 degrees in last follow-up at 20 months. And you can see that the results are pretty good in terms of the various scores they used and the satisfaction rate. And you can see this individual had a very good result in terms of his range of motion and stability. And this is an example of the CT arthrogram showing good healing of the capsulodesis. So this is, sometimes in Canada, we have wait lists and we book somebody for scope and remplissage, and then we, 6 or 8 months later, finally get them to surgery, and things have changed because they've had a few more dislocations. So this is an example of a, you have the scope anterior superior and you look in and you think, wow, actually, I probably shouldn't be doing arthroscopic stabilization in this procedure in this patient because the defect is large and there's inverted paraglenoid, which means significant bone loss. And this would be the view from the back. So in some cases, you can try the arthroscopic stabilization. However, you may want to actually remove the scope and do Latarjet if you can. We actually tried the arthroscopic here, but it's not the most ideal patient. You can see the inverted pair there. So we did our own study, randomized clinical trial, and presented the initial results in 2019. Since then, the initial 2-year results were published in JSE FRCSC 2021. And we were fortunate enough to win a few awards, as was referenced. And the study purpose was to compare patient-reported outcomes and objective clinical results between arthroscopic bankart repair with or without infraspinatus remplissage in patients with anterior shoulder instability with a hill-sachs defect. This is a prospective randomized clinical trial. We had 2 sites, one in Ottawa under Dr. Peter Lappner and one in Winnipeg. And we had the 2 groups, one being bankart repair with remplissage and the other being bankart repair without remplissage. And we studied up to 24 months. And since then, we've taken it out to an average 48 months. So the sample size initially is 108 patients, 54 per group. Inclusion criteria was 14 years or older and confirmed hill-sachs on CT or MRI. And we excluded those with a greater than 15% glenoid defect on AP diameter, arthropathy, infection, medical comorbidities, or WCB. So the technique was as described. Hill-sachs lesion confirmed intraoperatively. We had third-party randomization, and the technique of actual which anchors were used was at the discretion of the surgeon. So the anchors were placed, the bankart was repaired, and then the anchors were usually secured. So the primary outcome was the Western Ontario Shoulder Instability Score, or the WOSI score. And the secondary outcome was repeat instabilities, either dislocations or subluxations, and the ASES score, as well as simple shoulder test. Range of motion was also recorded, posterior shoulder pain, and we tried to do as many MRIs as possible for people who are available for hill-sachs healing or infill to be judged. So we initially had 108 patients, 6 were excluded post-randomization, and then we ended up with 50 in one group and 52 in the other. The loss to follow-up was about what we expected, about 16% in one group and 20% in the other, or 12% in the other, sorry. The demographics showed no difference in the demographics between those who had no remplissage and those who had remplissage. And the WOSI scores in follow-up up to 24 months showed no difference between the groups. But there was a difference, of course, between pre and post-operative scores. So this is curious that we show a difference in instability rates, but no difference in WOSI scores. We feel that either the score is not sensitive enough, or you need several thousand patients to show a difference. So redislocation at 24 months was in the no remplissage 9 and the remplissage 3. So it seems at first face value to be showing a difference. But the initial results were P 0.05, equal 0.05. So very close to being significant. But the hazard ratio was that no remplissage had 3 times greater risk of redislocation. Okay, so the defects were healing in most cases, just like Pascal showed, Pascal Bolo, more than 75% were healed on MRI. And range of motion was actually not too bad. There was some loss of range of motion at 12 months in external rotation and abduction of about 10 degrees. But then by 24 months, that was no longer significant. If we look at the high-risk patients, those who had a greater than 25% or greater than 25 millimeters hill-sachs lesion, then with the total numbers of those were 14 in no remplissage and 26 in the remplissage. And if you look at redislocations, it was 4 in the no remplissage and 0 in the remplissage. So more importantly, we got into medium-term follow-up, which showed more significant results. And this is 4 years. And this was failure of 22% in no remplissage and 8% in remplissage. So significant difference, highly significant now at 4 years. This is the survival curve showing most of the dislocations occur or redislocations occur after first 20 months, so that you have to follow it out a while to see the big difference. So again, reiterating, there's 22% with, so if you do an arthroscopic stabilization on these patients without doing a remplissage, it's a fairly high recurrence rate, 22%. If you do a remplissage, it's down to 8%, which I would suggest is probably acceptable. So posterior shoulder pain, this is a knock or a concern re-remplissage, and we didn't find any difference between the two groups. What about return to sport? Any difference? Some people are worried that remplissage will prevent you from returning to overhead sports. Well, if you tease that out on the WOSI scores, no difference, because there's a specific question about return to sport. So in conclusion, arthroscopic remplissage versus bankart repair alone, no difference in patient-reported outcomes. WOSI, ASES, SST, both groups were improved versus pre-op status. Redislocations were non-significantly different at 2 years, but significantly different at 4 years. External rotation and abduction decreased at 12 months, and no difference in shoulder pain or return to sport. A high healing rate on MRI. So this is an introduction to remplissage. I hope there's some questions. Thank you again very much for inviting me. Love to entertain some discussion. Thank you very much.
Thank you very much, Professor. Prof, you can stop sharing your screen actually. Thank you very much, Professor, for this enlightening talk. Few questions from our side. Prof, in a case where there is a bipolar lesion with a significant glenoid loss, do you think a lethargy would be a reasonable alternative for a bankart and a remplissage?
Yeah, thank you for the question. The Latarjet is a good operation. It's been shown many times to be very successful in terms of decreasing recurrence rate. I use it personally between 15 and 25% of glenoid bone loss. I go to a Latarjet. More than 25%, or even more than 20%, some people will go to an allograft, a distal tibial allograft, just because there's a limit to the size of the coracoid that you can use, of course. So once you get very large lesions, a distal tibial allograft may be the best thing to do.
So which category of your patient best suits for a bankart plus remplissage? I mean, which one do you prefer, lethargy, and which one do you prefer, bankart plus remplissage?
So 0 to 15% glenoid bone loss, I'm going to do, with a hill-sachs lesion, I'm going to do arthroscopic bankart with remplissage. Between 15 and 25, or a failed arthroscopic previous stabilization, I'm going to do a Latarjet.
Thank you.
And greater than 25, I'll do a distal tibia allograft for greater than 25.
Thank you very much, Professor. And Prof, what is the best way to quantify the size of the hill-sachs? Is it a CT or an MR?
I think CT is the most accurate. However, there's now studies showing that 3D MRI, if you have that capability, is probably just as accurate. So CT, I mean, has the downside of radiation to a young patient. So there's always that small downside, but it is traditionally the gold standard.
Thank you very much, Professor. Prof, we are also joined by Loy. Loy Al-Khatib is an orthopedic surgeon based in Dubai and a former fellow. Loy, your questions to Prof.
Thanks, Dr. MacDonald, for accepting our invitation for the second time. Again, amazing lecture as usual. One of the questions is there any place to redo remplissage in case of this first remplissage failed, or you do something else? What would you approach for a failed remplissage?
Yeah, I think you have to ask yourself why it failed. If there's a very small glenoid defect, still you could try it again. However, you're going to be dealing with capsule, which is maybe chewed up a little. Remplissage. So my situation in most of those cases would be to go to a Latarjet. So I don't do too many repeat remplissage.
Do you have any experience with the hemicaps? It's so like the remplissage is all about to refill the gap, right? Is there any place for the hemicaps? Do you think they provide similar results?
I think, yeah, it's hemicap or humeral head allograft, I think are options for large hill-sachs lesions, usually greater than 20 to 25%. I only have done a few cases. So if you have a bipolar lesion, significant size, you may want to do a Latarjet plus a hemicap or Latarjet plus a humeral head allograft. So those are options for the very large hill-sachs lesion, especially bipolar.
Awesome. My last question. I would like to hear your comment or your opinion regarding the dynamic anterior shoulder stabilization. It's trending now, especially here in Europe. So I'm in Germany right now, and most of my colleagues, they are shifting to the DAS, the dynamic anterior shoulder stabilization, plus the Remplissage. What do you think about that? This new technique?
Yeah, just define that for all the listeners.
Excuse me?
Can you define the dynamic?
Transferring the long head of biceps tendon and put it in front of where the defect is, the glenoid bone loss.
Yeah, so I've seen this presented a few times. I don't personally have any experience. I think it may be something of future promise or future study, but I can't speak with any degree of experience on this. But it is an interesting procedure and maybe holds some promise for the future.
Awesome. Thanks again, Dr. MacDonald.
Thanks, Lai.
Thank you very much, Professor MacDonald. That's all the questions that we have for this session. Thank you once again for joining us and giving this fantastic talk.
Okay, thank you, and have a nice holiday season.
Bye-bye, Prof.